This is a this is a session for postgraduate students post MD DNB who are doing their DM, DNB, or fellowship in rheumatology in Maharashtra in different colleges or rheumatology centers. So the first part is a case presentation and followed by a guest lecture. The student who will be presenting today is Dr. Vaibhav. He's the first year DM resident at Pune. And we have renowned faculty from Mumbai today. Uh, First one is Dr. Sameer Rajadhaksha. He's a senior renowned rheumatologist at Gleneagles Hospital, Mumbai, with many years of experience. A second faculty is Dr. Lalana from LTMMC Medical College and Sion Hospital, Mumbai. She's a professor of internal medicine and in charge of the rheumatology clinic at Sion Hospital. A very warm welcome to both of you. Welcome to the session. So should we start?
Yes, ma'am.
Yeah, okay. So Vaibhav, you can start presenting.
Yes, thank you, ma'am.
Yeah.
Good morning, all respected faculty. I'm Dr. Vaibhav. I'm a first year resident at Bharati Hospital and under Kavita ma'am, our HOD of Department of Rheumatology. Today I'll be presenting a case of a 45-year-old male with chronic low backache and neck pain. Our patient is a 45-year-old male who's a rickshaw driver by occupation, Mr. X. He came to our OPD with chief complaints of low backache since the past 15 years and neck pain since the past for the past 8 years. History of presenting illness. The patient was apparently all right till 2009, that is 15 years ago, when he initially developed low backache. He says that he developed this backache initially in the right buttock, and this backache was insidious in onset and gradually progressive in nature, associated with early morning stiffness lasting for around 30 minutes to 1 hour. And this back pain used to alternate between both the sides of the buttocks, and it aggravated on rest, and it relieved with activity and as the day progressed. This also relieved with some painkillers which he took for this. The pain was associated with this pain was associated with night awakening. He says that early mornings he used to wake up due to this pain, and this pain was also non-radiating type. For this, he was prescribed some some painkillers, which he took for about three years, and he kept switching between the doctors without any definite diagnosis. And due to the persistent pain, he then started Ayurvedic treatment in 2014, which he took for 5 years. In 2015, he then developed neck pain, which was insidious in onset, gradually progressive in nature, which was non-radiating, and this also was associated with early morning stiffness. And since he was an auto driver, rickshaw driver, he had difficulty in driving his auto due to restriction of the neck movements. For this, he then consulted a physician, and he was started on oral steroids and painkillers, which he took again on and off. But with this, he said that there was improvement in symptoms of about 70 to 80%, and he was able to ride the auto back. Then he had progressive difficulty in driving when he was on this treatment on and off, with increasing difficulty of the neck movements while rotating his head. And also he had difficulty in maintaining his posture while sitting in the auto rickshaw. He kept taking medications on and off for this, and progressively his movements got more and more difficult, and he had to quit his job because of these issues. Patient also gives history of redness of eyes, which was on and off around 4 to 5 episodes per year over the last 6 years. He says that the redness was associated it came in a single eye, and it was alternating between the eyes itself. And this was associated with blurring of vision and painless. For this also, he took treatment. He said he took some eye drops, but we do not have any records. There is no history of involvement of small joints of the hands or the feet, no history of heel pain, no history of swelling of the entire finger, no history of scaly skin or excess dandruff, no history of recurrent diarrhea or blood in the stools, no history of any skin rashes, no history of fever, cough, hemoptysis, or weight loss, no history of dyspnea on exertion or chest pain. He has no history of contact with farm animals or any consumption of raw milk, no history suggestive of Raynaud's phenomenon, no history of any Zika symptoms, no history of frothy urine, puffiness of eyes, and nothing suggestive of any bladder involvement. Past history, he gives no history of any comorbidities like diabetes, hypertension, or tuberculosis. His family history, there is no history of any arthritis which runs in the family, or no history of even tuberculosis in the family. He has a mixed diet. His appetite was normal, and he presently, when he came to us, he says he sleeps adequately. He used to occasionally consume alcohol, and he's a non-smoker. So summary at the end of history, he's a 45-year-old man with chronic low backache, which was inflammatory type, chronic neck pain also, which was inflammatory type, and redness of eyes, which was on and off, painless, associated with blurring of vision, involving one eye at a time. Provisionally, I would like to think that this is a chronic inflammatory arthritis involving the probably a spondyloarthropathy with axial involvement.
Dr. Sameer, Dr. Lalana, you can ask him.
Any other history you're interested in asking?
Ma'am, he has no peripheral joint involvement, ma'am. No history of skin or nail involvement. No history of heel pain, ma'am. Or
Okay.
no history of chest pain when he on deep inspiration as well. He has no history of any TB, contact with TB in the past, weight loss, or respiratory symptoms like dyspnea on exertion, weight loss, hemoptysis as well, ma'am.
Okay. IBD related history of asked, no?
Yes, ma'am. He has no
Yeah.
history of.
Okay. Yeah. Go ahead. Yeah.
Yeah, just one point. So in the family history, na, I mean, because you are presenting a spondyloarthropathy.
Yes, sir.
So when you ask for history of one is of course history of any back problems in the family, but you should always also ask history of psoriasis in the family.
Yes, sir. Yes, sir. He did not have history of psoriasis, sir, in the family.
No, family history of psoriasis also is important.
Yes, sir.
So on history, basically you have differentiated this patient into a inflammatory back pain. Okay,
Yes, sir.
so how do you differentiate between mechanical and inflammatory back pain?
Yes, sir. Sir, inflammatory back pain is associated with stiffness, sir, early morning stiffness, which usually lasts for more than 30 minutes, up to an hour. Mechanical back pain, there is no stiffness, sir, usually. And inflammatory back pain relieves with activity, and the patients get better as the day progresses. Whereas mechanical back pain aggravates with activity, and they have more trouble towards as the day progresses, sir. Inflammatory back pain relieves with activity, and mechanical back pain relieves with rest.
Good. So since you are on back pain, on history, what are the red flag signs you would like to check, which warrants urgent, intervention in present patient with back pain? Red flag signs.
Sir, elderly age more than 60 years, sir, is one. History of weight loss is a red flag sign. Then
Right.
history of neuropathic symptoms, sir, radiating pains, or
So this is generalized. We are talking about a patient with back pain. You need to see what are the red flags.
yes, sir. Other than this, then
So basically, any patient who presents, age of onset less than 20 or more than 55, okay, then thoracic pain,
yes, sir.
nocturnal pain, fever, weight loss, bladder bowel dysfunction, history of malignancy,
Yes,
history of osteoporosis like chronic steroid use,
yes,
neurodeficit, and saddle anesthesia. So these are signs you should always remember, which are known as the red flag signs.
yes, sir. Yes, sir.
Yeah, I think we can go on. Anything else?
No, continue. Yeah.
So in your provisional diagnosis, you also should mention that patient is likely to have uveitis, or you would like to rule out uveitis.
Yes, sir.
So it is inflammatory chronic. It's an inflammatory back pain plus probably uveitis.
Yes, sir. Okay,
And which uveitis it will be? Commonly, which uveitis is seen in spondyloarthropathies?
Spondyloarthropathies are axial is associated with recurrent acute anterior uveitis.
Yeah, very good.
Can I go ahead?
Yeah.
General physical examination. Patient has a pulse rate of 92 beats per minute, which is regular, normal volume, normal character, no radial or radiofemoral delay with all peripheral pulses. pressure of 134 by 88 millimeters of mercury in the right arm supine position, respiratory rate of 20 cycles per minute, which was abdominal thoracic type, and temperature of 98.5 degree Fahrenheit. He has a height of 168 centimeter, weight of 75 kgs, with a BMI of 26.57 kg per meter square. On general physical examination, he has no signs of pallor, icterus, or edema. His hair, no evidence of psoriasis in the scalp or the type of was also normal. There was no pitting, anaphylaxis, or nail changes seen. There was no psoriasis in the scalp as well.
Vaibhav, we are not very clear. Huh? Voice is cracking. So just see if you want to set to the. Vaibhav, you're there? Just wait, I think he's gone offline.
What happened?
No, I think he's net. I think there's some technical issue. I think he's just gone offline. I'll just call him.
Hello, ma'am. Can you hear me?
Yeah, just a little louder, and your screen is gone. You'll have to share your slides again. No?
Just one.
Yeah,
Lights went off. The Wi-Fi. I'll just
so the lights went off. Okay. Yeah, just go to slideshow. Yeah, and this slide you can maybe read again louder.
Yes, ma'am. Can you see my slides, ma'am?
Yeah. Now you can see, can hear you also. Just loud and clear. Yeah.
Yes. On general physical examination, there were no signs of pallor, any pallor, icterus, or edema. On examination of his hair, there was no evidence of psoriasis or excess dandruff. The conjunctiva, cornea, and fundus examination was normal. Oral cavity was normal. There was no evidence of any pitting or onycholysis seen in his nails, and there was no evidence of any psoriasis or skin lesions as well. Musculoskeletal examination, the spine, there was no obvious deformities of the on inspection, and the overlying skin was normal. There was no palpable tenderness. Measurements, wall to tragus was 15 centimeter. Lateral flexion, right side was 4 centimeter and left side was 5 centimeter. The expansion of chest was around 2 centimeters. Schober's test was 3 centimeters. The intermalleolar distance was 60 centimeters. On examination of the neck, the flexion, extension, and lateral flexion as well was restricted. And the rotation on the right side was restricted after 45 degrees and left side after 30 degrees. There was no sacroiliac joint tenderness, and the patient was unable to do the Faber's test due to restriction of the movements of his hip. On movements of the hip examination, the patient had a flexion deformity of around 30 degrees on the right side and 20 degrees on the left. And extension was restricted with around 10 degrees of movements on both the sides. Adduction 10 degrees of until 10 degrees. Abduction 30 degrees on the right and 20 degrees on the left. Internal rotation was 20 degrees on both the sides and external was 30 on the right with 20 degrees on the left. And movements were restricted in the hip as well. The other joints did not have any restriction of movements, and there were no other swollen tender joints. Systemic examination per abdomen was soft, non-tender, no organomegaly, and the bowel sounds were heard. Respiratory system, bilateral normal vesicular breath sounds were heard, no added sounds. Cardiovascular system, both the heart sounds were heard normally, no murmurs. Higher mental functions were intact, and there were no focal deficits on neurological examination. So summary, 45-year-old man having chronic inflammatory low backache and neck pain for more than 8 years with history of recurrent red eye in the past. So my diagnosis here would be axial spondyloarthritis with a probable recurrent uveitis.
Vaibhav?
Yes, sir.
Yeah. Can you describe Schober's test?
Yes, sir. Schober's test, we take 2 points, sir. One is drawn at the level of the sacral dimple, and the other point is taken 10 centimeters above that. and the patient is, and this is done when the patient is erect, sir, supine. And then we instruct the patient to bend down with his knees without flexing his knees and try to touch his toes. And then we check for the difference in this. There should be an increase of this distance by more than 4 centimeters, sir. If it is lesser than that, that means there is restriction in the lumbar spine.
What about chest expansion? Can you describe that?
Yes, sir. Chest expansion at the level of the patient is asked to take a deep inspiration after full expansion, sir. And this change has to be more than 4 to 5 centimeters, sir. Anything less suggests that there's a thoracic involvement, sir.
Less than 2.5 is significant.
And how do you do Faber test, Patrick test?
Yes, ma'am. The patient in the supine position, we first flex the knee and then slowly externally rotate the leg at the hip joint and place it on the opposite knee. And then we place, with stabilizing the opposite SI joint, we apply pressure on the knee of the side we are examining and check for tenderness. And if the patient complains of tenderness in the buttock, then that SI joint is in.
Vaibhav?
Yes, sir.
Yeah. So in your diagnosis, you also mentioned that he probably has a hip involvement.
Yes, sir. Yes, sir. So for bilateral sacroiliitis with the cervical and
Dr. Mr. Prasad, just mute the others, please. Yeah. Continue. Sorry, continue.
Continue.
yes, sir. So axial spondyloarthritis involving the cervical spine, the bilateral sacroiliac joint, and the hip joint with the probable recurrent uveitis, with no other extra-articular manifestation.
Which could be other differentials?
Ma'am, under the domain of the spondyloarthropathies, we can also maybe have kept psoriatic arthritis in mind, ma'am, because around 15 to 20% of these cases can manifest with arthritis alone.
Right.
But since it is more than 15 years and he has no family history of psoriasis and this thing, I thought to not include this in. And he has no.
How can it be dish?
Vaibhav, I cannot hear you. Be a bit louder.
Yeah.
Can you hear me now, sir?
Yes.
Yeah.
Yeah.
Sir, I was saying psoriatic arthritis, this, I mean, can be a possible DD, but since it has been more than 15 years and there's no evidence of any skin lesions and there is no family history as well, so I thought to not include it in the final DDs as well, ma'am.
Okay. Why can it be dish?
Yeah, yes, ma'am. Ma'am, dish usually is seen in more than 50 years, obese, diabetics. It is a non-inflammatory type of condition, ma'am. But this patient is giving us inflammatory type of pains. So, and also it involves mainly the cervical, the lower thoracic and the sacroiliac involvement is not seen in dish.
Okay, right. You had a history of unpasteurized milk and all, Why did you ask that?
Ma'am, that was just to rule out brucellosis, ma'am, which can be which can cause chronic involvement of the SI joint, but that is again it is usually asymmetrical. And again here this patient is having more than 15 years, ma'am, and this is the uveitis here is recurrent and resolving in between. That goes against brucellosis again, ma'am, which should the uveitis should be persistent and it would be asymmetrical involvement, and there is no history of contact with animals. So.
Right. Okay.
In fever, they usually have fever.
Fever, yeah.
Yes, ma'am.
Yeah.
Fever.
Okay. Okay, continue.
So what is inverse psoriasis or cryptic areas where you should look for psoriasis, even if you You don't obviously see.
And psoriasis is usually seen on the extensor aspects of the elbow, of the knee, and but inverse psoriasis is seen in the on the flexor aspects now, uh, on the inside of the elbow, in the axilla, submammary regions. And the cryptic areas to check for psoriatic patches are retroauricular areas now, and the gluteal clefts,
Umbilicus and
Umbilicus, perineum.
yeah, hairline posterior. Yeah. So you can others miss it. Continue.
Gluteal cleft also. You mentioned gluteal cleft.
yes, sir, gluteal cleft.
Yeah, continue. Yeah.
Yeah. Ma'am, we asked for routine CBC,
Louder, louder, Vaibhav.
Louder, Vaibhav.
yes, ma'am. We asked for routine investigations like CBC, which showed hemoglobin of 13.3, total counts of 6,900, platelets of 3.93 lakhs. ESR was 48, CRP was 57.8. Both the inflammatory markers were elevated. AST/ALT was normal. Albumin was 4.1. Creatinine was 0.9. We got an HLA-B27 for this patient by PCR, which was positive. And since we were planning biologics for this patient, we also got a workup for latent TB, IGRA as well as MAN2, which were again negative. Patient had some imaging done outside, so I will.
Vaibhav, just wait. On
Yes,
the investigations chart, so the
yes, sir.
hemoglobin is 13.3, na?
Yes, sir. Yes,
So what
sir.
will you suspect if the hemoglobin is low?
Sir, it can be
Or
part of the
if
chronic
the patient has low
inflammation.
hemoglobin, how would you approach that?
Sir, it could be due to the chronic inflammation, sir, anemia of chronic disease due
Yes.
to the inflammation. It can be due to the painkillers he's been taking on and off, sir. The NSAID induced probably gastritis or blood loss, sir. Or as well, it can be part of IBD, sir. If the patient has had IBD, then he would have had lost blood by dysentery or blood in the stool, sir. That could
So,
also be one cause of low HBs.
so based on that, what other tests would you advise?
Sir, we could get a stool for occult blood, sir,
Yes.
to see for any blood loss. Other than that, we can see for ferritin, sir. If ferritin
Sorry.
is high, ferritin, sir, ferritin
Yeah.
levels. So if it is high, then it goes in favor of chronic disease, sir. If it was low, maybe iron deficiency and loss of blood, sir.
Yeah.
Somewhere
Any
probably.
other stool test? If there is evidence of GI blood loss and patient has chronic intermittent diarrhea.
Sir, any OVA and cyst screening for parasitic infestation, sir?
Okay. Anything else?
In this setting,
Oh,
In
sorry.
this setting, any stool test you would advise if you suspect GI blood loss, not because of NSAID induced gastropathy from the lower GI tract?
Sir, Boy test, sir.
Stool calprotectin.
Calprotectin. Sir, for the IBD,
Yes, yes. So these are
yes.
three differentials. Na? As you spoke, one is anemia of chronic disease. If there is second is GI blood loss because of either chronic NSAID use or secondly to rule out IBD.
yes, sir. Yes, yes.
Yeah, yeah. You can go ahead.
Right, sir.
Just be louder. Your voice is very low, Vaibhav.
Yes, sir.
So I think
Uh,
on the investigation, one more question.
yes,
Just
sir.
go back to the yeah.
Yeah, yeah. So what about if this patient has proteinuria?
Sir, renal involvement in spondyloarthropathy can be IgA nephropathy.
Yes,
That could explain the proteinuria.
yes. And see, this patient has a long-standing AS, huh? Since
Long-standing
15 years. Huh?
disease.
Yeah. So what
Can
are the
be
differential diagnosis there apart
amyloid,
from IgA nephropathy?
secondary amyloidosis, sir, in this
Yes,
patient.
amyloidosis. So that will have
Yeah.
massive proteinuria.
Yes, sir.
And what about liver? If the liver enzymes are abnormal, huh?
Yes, sir. So
What
no, they're
what is the
normal, sir.
commonest thing you see?
Hello, sir.
If there are liver function test abnormalities, raised liver enzymes in the
Yes, sir.
patient with spondyloarthropathy, probably if the patient also had psoriasis. So what is the commonest liver condition associated?
Sir, we can think of non-alcoholic steatohepatitis, sir.
Yes,
NAFLD
NASH.
and NASH. because of the metabolic
So
dysfunction
that term
also.
has changed now. Huh? It is no longer NASH. It is MAFLD.
MAFLD, MAFLD,
NF,
sir.
It is MA, metabolic, MAFLD.
Yes,
MASH,
MA.
MASH.
MASH, yeah. Okay. Okay, go ahead.
yes, sir. Uh, we had an X-ray of this patient, X-ray of the hip with bilateral sacroiliac joints, which showed grade 4 SI joint ankylosis, and at the hips as well, there was reduced joint space. Uh,
Sorry,
uh,
Vaibhav. I'm sorry, but
sure.
let's. I think one more question on the investigations. Huh?
Yes, sir. Yes, sir.
About HLA-B27. So, how many of them are
Yes,
HLA-B27 positive? Huh? Can you tell us about the HLA-B27 positive across the spectrum of spondyloarthropathies?
yes, sir. HLA-B27 is found to be around 90% positivity seen in axial spondyloarthropathy, sir.
Yes.
In the second most common is reactive arthritis, which constitutes around 40 to 65%, sir.
Hmm.
Then it is IBD related arthropathies, which again around 30 to 50%, sir. Then psoriatic arthritis, which has around 20 to 40% positivity,
Yeah.
HLA.
So, B27 positivity is not the main thing, huh, when
Yes,
we make the diagnosis. Yeah.
yes.
Okay. Go ahead. Again.
How does HLA-B27, what is the role in pathogenesis of ankylosing spondylitis? The genetic or the pathology, do
Yes,
you
ma'am.
know about it, the theory?
Yes, ma'am. There are three main theories, ma'am. One is the arthritogenic peptide theory, ma'am, where the HLA-B27 presents are self antigens of the synovium and emphasis to the CD8 system because HLA is part of MHC2, ma'am.
Mhm.
And this causes inflammation at these sites, causing the symptoms, signs and symptoms of axial SpA. But this was disregarded because CD4 cells were found to be a driver of this disease, ma'am. Other than this, there is HLA, yeah, endoplasmic HLA misfolding causing
Misfolding.
endoplasmic reticulum. Yes, ma'am, misfolding causing endoplasmic reticulum stress and protein uncoupled protein response, ma'am. That also causes downstream inflammation. Other than this, HLA-B27 expresses itself as homodimers on the cell surfaces, which are again recognized as antigen, and that again causes downstream inflammation, ma'am. Other than this, there's a gut dysbiosis theory also, ma'am, and even the ERAP, ma'am, endoplasmic reticulum aminopeptidase one theory, which usually causes terminal cleavage of the N-terminal aminopeptides, and due to loss of function of this, can cause again inflammation and the symptoms.
Okay, carry on.
Yes, ma'am. Ma'am, X-ray of the hip was, we got the X-ray of hip with bilateral SI joints, which showed a grade 4 ankylosis in the SI joint bilaterally. And on the hips, we saw reduced joint space. X-ray of the chest AP view, there was a fusion of the vertebral bodies seen, giving the appearance of a bamboo spine. And at the lower dorsal levels, we can see the fusion of the anterior spinous processes, suggestive of the dagger sign. This is a zoomed in image of the same X-ray. Here we can see these marginal syndesmophytes as well. He had an MRI from outside. And this is a T2 image showing the
Wait.
lower.
While on X-ray, wait.
Go back to
Yes,
the.
Yeah, X-ray. So on X-rays, is there a way you can differentiate between ankylosing spondylitis and the other spondyloarthropathies like IBD, psoriatic? Is it different in the X-ray features?
yes, sir. In axial spondyloarthropathies, we have marginal syndesmophytes, sir, which are towards the midline. In
Yes.
psoriatic, we see a jug-handled type of syndesmophytes, sir, which are away from the midline, sir, away from the borders.
Okay. What about sacroiliitis?
Uh, Sacroiliitis, sir. Sir, bilateral usually seen in ankylosing spondylitis, sir,
Yes.
and it is asymmetrical in psoriatic, sir.
Very good. What about different area of the spine? Is there any difference between the spine involvement between ankylosing spondylitis and other spondyloarthropathies? Say psoriatic.
Um,
So
Sir,
psoriatic, the
most,
cervical spine is more involved, na?
yes, sir. Yes,
Axial psoriatic arthritis. Okay, go ahead.
yes, sir.
So while on X-rays only, sorry, while on X-rays, how do you
Yes, sir.
differentiate between ankylosing spondylitis and dish?
And this,
And what is dish? Can
sir,
you tell me what is dish?
yes, sir. Diffuse idiopathic Uh,
Skeletal.
Skeletal hyperostosis.
Yes, very good. So, how do you differentiate on plain radiographs between dish and ankylosing spondylitis?
So dish is again seen in the cervical part, sir. There is calcification of the anterior longitudinal ligament, sir, giving a flowing candle wax type of appearance in
Yes,
dish.
very good.
And there is a region of lucency seen between this calcification and the anterior border of the vertebral body, sir.
Right.
So that is not
What?
seen in
Better
axial.
seen in the lateral.
What else?
That is lateral, no, lateral.
Yeah. What else?
Uh,
Sacroiliac joint involvement.
So that is not there in dish, but you see it
Yeah.
in axial
Yeah.
spondyloarthritis.
And what about those axial lesions? They are on which side of the spine, left or right?
So they are seen on the left side, sir, because right side
Right
there is
side.
a
Right
pulsation.
side.
They are more on the right.
Yeah. Right. Sorry, sir, right side, because on the opposite side you have the great vessels.
Yeah,
Aorta.
exactly.
The aorta.
Okay, thanks.
If
You can
you
go ahead
on
now.
the same X-ray, if you get an intervertebral disc calcification, then
Ma'am? Ma'am, sorry.
if in the same X-ray,
Yes,
if
ma'am.
you can see intervertebral disc calcification,
Yes, ma'am.
what would be the other DD?
Ma'am, we can also see it in rare cases of fluorosis, ma'am.
And
Alkaptonuria, ma'am.
very good. Okay.
Hemochromatosis.
Yeah.
Yes,
Ochronosis.
yes, ma'am. This was the MRI which he had gotten it done. T2 weighted images showing hyper intensity on the in between the vertebral bodies. We can see there is erosion, sir, suggestive of a probable shiny corner sign, or uh, or also called as the Roman
Vaibhav,
corner.
please be louder.
Sir, here we can see hyper intensities at the edges of the vertebral body, sir, probably suggestive of a shiny corner sign, sir, sclerosed vertebral edges.
What is that lesion known as?
Sir, Anderson's lesions.
No,
Uh,
Romanus.
Romanov sign. Romanov sign.
Bone lesions.
Anderson is a spondylodiscitis.
Yes, sir. So that is involving disc. Yes, sir.
Okay, go ahead.
This is the same MRI showing the cervical region where there is fusion of these posterior osteophytes, so causing difficulty in his neck movements. So this was the investigation. Based on this, we clinically, diagnosed him with axial HLA-B27 axial spondyloarthritis, sir. And then we initiated on physiotherapy, and we started him on TNF alpha inhibitor, adalimumab, and NSAIDs on a SOS basis, for which he showed good improvement, sir. His BASMI when he came to us was 5.9. After 2 months, it has dropped to 4.1. He's on regular follow-up with us.
Which other scores are there to check?
Ma'am, we can also check disease activity with BASDI, ma'am, but this is mainly a patient, it is the subjective scoring, ma'am, BASDI.
Hmm. Hmm.
Other than this, we can also get ASDAS, ma'am. ASDAS CRP is more reliable than our BASMI, ma'am, because it also involves the lab component of CRP in it. Less than 1.3 is normal and more than 3.5 is severe, ma'am.
Okay, Vaibhav.
Yes, sir.
Yeah. So tell me one thing. What are the predominant cytokines which we target in ankylosing spondylitis?
Sir, we target TNF alpha, sir.
Yes.
Then
And
interleukin 17, interleukin 22, sir.
yeah. So how do you differentiate? Na? If you tell me between the axial skeleton, then the skin, peripheral joint, entheses, is there any difference in the cytokines?
Uh,
Because see, based on this cytokine hierarchy, we choose our biologic therapy.
yes, sir. TNF alpha is acts on all these domains, sir. TNF alpha inhibitors, the arthritis as well as enthesitis and even uveitis, except for etanercept, sir, among the TNF
Yes.
alpha
So it's a fusion
inhibitors.
protein. So monoclonals work. So in
Yes,
which conditions you won't use etanercept?
sir. We do not use it in uveitis and also inflammatory bowel disease associated arthritis, sir.
Yes, very good. What about IL-17 inhibitors?
Yes, sir. IL-17 main, also we can use, sir, but they are mainly used in association with psoriatic arthritis, sir.
Okay. What about uveitis and IBD? Can you use them?
What is IPD? So, ILs, when we use IL-17 inhibitors, sir, like ixekizumab, to
Hmm.
prevent the formation of autoantibodies, we also use methotrexate, sir. So that
But
can,
is the guidelines do the guidelines mention that we should use methotrexate with anti-TNFs
no,
to prevent
no, sir.
autoantibodies? No,
No,
no.
sir. No guidelines, sir. Hello.
Yeah, you can hear me louder.
No, no, ma'am. No guidelines say that.
So in IBD associated, you use IL-17 or you don't? And which one will you prefer?
In IBD, we prefer again TNF alpha inhibitors itself, ma'am.
Or
Other than this, we can use natalizumab, vedolizumab, ma'am, and even tofacitinib.
what about
Infliximab.
Ma'am?
Infliximab.
Yes, ma'am. Infliximab.
Infliximab.
Yes, ma'am.
Hmm.
Infliximab can be used in IBD associated arthritis.
And role of TOFA.
Yes, ma'am. TOFA has recently been demonstrated to show some benefit, so I think we can use, ma'am. I'm not sure about this. Uh,
yeah, continue.
I'm not sure regarding the role of tofacitinib in IBD.
They have shown improvement with 41% of TOFA in ASAS 40.
Lalana, I can't hear you. Maybe you can switch off one instrument. You're using two gadgets, I think, two
Yeah,
devices. Switch off one.
yeah.
Yeah.
So even tofacitinib has been used, and they have seen around 40% improvement in ASAS 40, okay, as against 30%, 13% in placebo. So it can be given.
Yes, ma'am.
Okay, yeah.
Yeah, Vaibhav.
Yes, sir.
So tell me about what are the markers we look at which are associated with an increased risk of radiographic progression.
Yes, sir. Increase risk. Sir, uh, very high inflammatory, yes, sir, of more than 30 and raised CRP levels, sir.
Okay,
Uh, uh, in the male
male
gender,
gender,
sir.
yes. Then
And other than this, rapid progression of symptoms, sir, and formation of within 1 year
syndesmophytes.
involvement of the hip syndesmophytes, sir.
Yeah, the presence of syndesmophytes, and apart from that, obesity and smoking.
Yes, sir. Obesity and smoking.
There is one
Yes.
question in the chat box. In Fabus test, pain is at the same side, is considered positive or the opposite side?
Ma'am, there are in two schools of thought, ma'am. Some studies say that on the same side when we squeeze, mean press, that is positive. There are a few other studies which say that the opposite side. Um,
Vaibhav,
yes, sir.
see, in all the investigation which you have done, it's a long-standing AS. Any
Yes,
other
sir.
indication, anything you would do for this patient? Any other screening you would like to do?
Uh, for
Uh,
HIV we
no,
have
no,
done, sir.
not that. So patient has a long-standing AS, has probably issued alternative therapy, steroids. What else you would like to screen for? Though he's a
Uh,
male.
DEXA's cancer for the bone health, sir.
Yeah, so
Bone
basically
density.
osteoporosis. But are there any fallacies of DEXA scan in this group of patients?
since there are
What-
presence of syndesmophytes, sir, it can be a false
Yeah.
false reading. Sir. So
So
false.
what else can be done? QCP.
Um, yes, sir.
Yeah. So other thing you will screen for is vitamin D deficiency and also screen for osteoporosis. What else? Anything else you would screen for?
Um,
So now you have
um,
treated the spondyloarthritic path. What else now you will look for, which is non-rheumatology, you can say? What other things you should always consider?
sir, for
What
his
do untreated rheumatological problems can lead to? Cardiovascular disease.
yes, sir. They are at risk for cardiovascular
Yeah,
mortality.
so that you'll have to always screen for cardiovascular disease.
Yes,
Secondly,
sir.
anything else?
Um, physiotherapy we can advocate, sir, for.
Yes, so physical has to be added for all. No, before that, mental health, depression,
Yes, sir. Depression.
depression.
Also, yes, sir. Depression, smoking, even
Yeah, so all that things are
fibromyalgia,
very important.
reasons
And
for
of course,
drugs.
physiotherapy is mandatory. So,
Yes,
is
sir.
the smoking have any hazards for this group of patients?
Yes, sir. Smoking has been found to cause increased radiographical progression in these patients, sir. So we have to advocate them to stop smoking, cessation of smoking.
Does the effect of biologics also are affected by any factors?
Yes, sir. Smoking can cause drug failure, smoking,
Yes,
then obesity, depression,
yes, very good.
uh, fibromyalgia part, sir, if the patient does. And over time, the patients also develop anti-drug antibodies, which can cause
Now
failure
you have
of.
put the patient on adalimumab, right?
Yes, sir.
Yeah. So, what would you monitor?
Hello, sir.
What would you
Sorry,
monitor now?
just.
You are a patient in a biological, nah?
Yes, sir.
So, how would the follow up be, and what would you monitor
Sir, we
apart
will
from, of
ask.
course, signs and symptoms?
Yes, sir. We can get CRP values, sir, for him 3 monthly and calculate our ASDAS score, sir, to see. There should be an improvement at least of more than 1.1 to call to say that the patient is responding to therapy, sir. And if he is not responding, then after 3 months, we have to consider switching to another biologic, sir.
So, what
Otherwise,
is
we
the
can
difference
continue.
between a primary non-responder and a secondary non?
Sir, primary non-responder, within the 3 months, they do show response, sir. But in the long, after that, I think, sir, I'm not sure regarding the time duration, sir. But due to anti-drug antibodies, there is the secondary drug, I mean, later they show uh, tolerance, sir. I mean, resistance against the response to drugs. Hello? Hello?
Hello, Dr. Samir, you're there? Hello.
Yeah, can you hear me?
Yeah, I think we lost you,
Yes, sir.
Dr. Samir. You can continue.
Yeah. So, what is the difference between a primary non-responder and a secondary non-responder?
Vaibhav, just repeat it. Yeah.
Sir, the primary, within the first 3 months of therapy itself, they don't respond, sir, to the drug.
Louder, louder.
Hello, sir. Sir, in the
Yeah.
first 3 months of therapy itself, when there is no response, we call them primary, so primary non-responders. And over the
Hmm.
course of duration of treatment, they developed anti-drug antibodies, sir. So probably they stop responding to treatment later on also.
Okay. So, does this make any difference for choosing the next biologic?
Um, yes, sir. We have to give them in the same class. No, actually, sir, if they have shown good clinical response and if they're in remission for 2 years, we can consider tapering and stopping therapy itself, sir. But if
No,
they're
no, not
still.
that way. So
Yes,
when a patient does not respond by 3 months, as you said, na, and
yes,
the
sir.
second scenario is when the patient does not respond after a period of time. So in either case, he has failed the first biologic. So how
Yes,
would you choose the next biologic
sir, in the same class only we have to choose the next biologic, sir.
for both the case scenarios?
In the first one, we have to choose in same class, sir. In the second one, when he has developed drug antibodies, we have to probably switch class, sir, because they have developed antibodies against that type.
Okay, go ahead. Yeah,
Okay, I think we will just wind up. Huh?
yeah, it's time, na? Yeah.
Yeah, yeah. So You want to
Anyway.
ask concluding question and then you can give a feedback.
Fine.
Is there
Good,
any
Vaibhav.
disease progression in the non-radiographic and radiographic axial spondyloarthropathy?
Hello, ma'am.
Is there any difference in
Yes, ma'am.
progression of the disease
Yes,
in
ma'am.
radiological and non-radiological axial spondyloarthropathy?
Yes, ma'am. The changes when we see on an X-ray are late usually, so they are the radiological changes. But early subtle changes like bone marrow edema and all are seen in MRI, which is a non-radiological type of spondyloarthropathy.
Mm.
So
And
Madam
nowadays
is
it is
asking,
differentiated like that, na? It is axial and radiological and non-radiological axial
Yes,
SPA.
it takes like
Okay.
5 to 9 years to develop radiological changes from the onset of symptoms, ma'am.
Good presentation.
Dr. Sameer,
Yeah, thank you.
so any comments or suggestions?
No, it's good and good presentation.
Good presentation.
I think they should just present more.
Yeah, I think it's really more practice and speak louder and clearly.
Yeah, practice and but good presentation.
Thank you, sir. Thank you, ma'am.
Thank
Good,
you so
Vaibhav.
much, Dr. Sameer, Dr. Lalana. Very good questions, and I'm sure the students have learned a lot and little more, guidance for reading. Thank you very much for sparing your valuable time on a Sunday morning. And Vaibhav, you can stop sharing your slides.
Yes, ma'am. Thank you so much, ma'am.
Yeah. Okay, so now we have Dr. Ramya, you've joined. Dr. Ramya?
Yeah.
Yeah, hello, good afternoon. Can you start sharing your screens while I introduce you?
Yeah.
So you just check out your slides. Dr. Ramya, are you able to share your slide screen?
I'm not able to. 1 second, I'm just.
Yeah.
I'm not able to. Shall I mail it to you, ma'am?
Mr. Prasad, you're there?
Yes, ma'am.
हाँ मैम का शेयर स्लाइड्स नहीं हो रहा है.
एक minute. Shall I call her?
Yeah,
It is
yeah.
some issue with my laptop, I think. I can share the slides so that you can project. That will be better.
Okay. Mr.
Ma'am, which laptop are you using?
Apple.
Apple. Okay.
Ma'am.
And are you using Notes or PowerPoint?
PowerPoint.
No, the software which you are using for PPT.
PowerPoint.
PowerPoint. Okay. Hang on. Ma'am, shall I give you a video call?
Yeah.
Hang on.
You have my number.
Yes, I do. Yeah.
Yeah. Just wait for 5 minutes. Huh? We'll come back in 2-3 minutes. Yeah.
Hello.
Yes. Yeah, just start from the first slide and just check if the slides are moving. Go for slideshow. Yeah. Yeah, just change one slide also and check. Yeah, I think that's fine. Should we start then? Yeah, the slides are seem fine.
It's not moving now, I think. Is it okay? Is it moving there?
Yeah, it's moving. Yeah. Just go back to the first slide. Starting slide, yeah. So I'm going back. Oh, got logged out.
Am I not there? What is it?
Yeah, now we're stuck at one slide, I think. Yeah. Yeah, just go to the first slide. Yeah.
Now it is in the first slide. Shall I start now?
Yeah, I'll just introduce you. Yeah, first of all, a very good morning to you, Dr. Ramya. Thank you for accepting the invitation. Dr. Ramya is a professor, Department of Clinical Immunology and Rheumatology at St. John's Hospital, Bangalore. She has been a faculty in multiple national conferences. She has 21 publications, and her special interest is pregnancy in lupus, scleroderma, and myositis. Today, she shall be talking on a very important topic and patients which entity we see very often, vasculopathy and its contribution to fibrosis and systemic sclerosis. Over to you, Dr. Ramya.
Yeah, thank you, ma'am.
Yeah.
So this was discussed in our academic sessions last month. This is published in the Current Opinion Rheumatology recently. So we have been interested in this vasculopathy, the severe subsets of vasculopathy in scleroderma, which we see. So I just wanted to understand its role in the pathogenesis in somewhat of in detail. And this was discussed in the recent review articles. I went into the details of some of the papers which are cited in this article, and let's hope the audience will find it interesting. So this is the classic teaching. Systemic sclerosis is a complex autoimmune disease of unknown etiology. It is characterized by three components: excessive fibrosis, vasculopathy, chronic inflammation, and immune dysregulation. So in today's talk, we will be discussing in detail about vasculopathy, what contributes to vasculopathy, and its interaction and or its role in contribution to fibrosis. As we all know, systemic sclerosis is a disease which is characterized by excessive fibrosis. So the more at the outset, I would like to introduce to these two morphological patterns of vasculopathy, which is seen in histopathological section of systemic sclerosis. One is destructive vasculopathy, which is mainly seen in the capillaries. So this is what we visualize when we do nail fold capillaroscopy. So these endothelial cell injury will lead to loss of these capillaries and formation of neovascularization. But what happens in medium-sized vessels, whichever the arteries which have the muscular layer is, they develop something called as fibroproliferative vasculopathy. This leads to the disease manifestations such as scleroderma renal crisis. It is probably involved in pulmonary hypertension and severe forms of vasculopathy like gangrene. So let's try to understand what happens at during each of these pathological processes. So as you know that the nail fold capillaroscopic changes are representative of the microvascular changes which are happening in scleroderma. And as you know, the VDOS spectrum, that is the very early diagnosis of scleroderma also, these nail fold capillaroscopic changes are part of the diagnosis. So that means that this is something which happens very early in the disease pathogenesis. It is well accepted that there are various lines of evidence to suggest that vascular injury and vasculopathy probably happens at the outset in scleroderma. So let's try to understand what are the contributors of vascular injury. There are two main things which probably contribute to vascular injury. One is viral infection. Viral infections are generally common. So in an appropriate context, like a genetically predisposed host, these viral infections may lead to vascular injury, which is not repaired in an appropriate way and may contribute to pathogenesis. The other group of uh, factors which will lead to vascular injury is some antibodies like anti-endothelial cell antibodies and other antibodies of this G protein coupled receptor, which I will be discussing in detail. So the pictorial representation this side is mainly depicting the vascular injury which happens early. So during the initial processes, the vasculopathy will lead to edema. So this, as we all know, during the clinical history of the patient, the early patients will have these kind of an edematous phase. So that is mainly due to the vascular leaking. So these endothelial injury will lead to a dilatation, destruction of the capillaries and leaking of the endothelium, which will lead to edema. So this is what is described here. Some of these capillaries and lymphatic vessels, there is some amount of edema, which you can see as white spaces surrounding the vessels. In electron microscopy, you can see that there is swelling of the endothelial cells and there is detachment of endothelial cells from the pericytes. As well as what they have depicted is even during the initial phases itself of the endothelial injury, there is infiltration of inflammatory cells. The CD45 cells are hematopoietic in origin. So let's, the other lines of evidence which is suggestive of these viral infections as an initial inciting event of endothelial injury is this study where they have looked at the human endothelial cells from the lung. So these were studied for their gene expression, and what they found is all these endothelial cells from the lung are expressing genes associated with interferon pathway and innate immunity pathways which are involved in antiviral responses. So this is another line of evidence, not only in periphery, even in internal organs, endothelial injury and endothelial involvement secondary to the antiviral responses. So that is evident even at the outset. So the other lines of evidence for this viral infection leading to endothelial injury is the fact that we already know that CMV and EBV can cause endothelial. They can infiltrate into the endothelial cells and monocytes. Then they can lead to endothelial apoptosis. It is also found that there is increase in this parvovirus copy number in bone marrows of scleroderma patients, and it has been associated with increased endothelial injury as well as fibroblast transformation. So coming to the next set of factors which are involved in endothelial injury are endothelial cell antibody. So how this endothelial cell antibody is involved in pathogenesis is, it is known that this when you add this endothelial cell antibody to vascular endothelial cell and in the culture medium, it leads to release of endothelin-1. Endothelin-1 is further involved in the pathogenesis of something called as endo-MT, that is endothelial mesenchymal transition, which is an important contributor of fibrosis. This also leads to endothelial cell apoptosis. It is known to mediate the crosstalk between endothelial damage and fibroblast activation. So this is the role by which this anti-endothelial cell antibody plays in pathogenesis of scleroderma. See, the other important set of antibodies which are involved in pathogenesis are mostly from G protein coupled receptor. During the study, when I was reading for this particular topic, I found that there are symposia which are conducted just concentrating on these G protein coupled receptors. They have been implicated in lot of conditions, wide variety of conditions, like some of the conditions like post-COVID syndromes, both acute and chronic fatigue syndrome, some of the neurological disorders like NMDA receptors, etc., stroke and other rheumatic diseases. So the receptors of interest for us are against endothelin and angiotensin. They can act by various ways. Not all of them are functional. Some of them appear as natural ligands of the molecules which are there on the endothelium. Some of them act by a direct agonistic role they are known to have. These are called as functional effects. Some of them act via synergistic or antagonistic. That is the natural ligand for all these receptors. Their effect will be accentuated by the presence of these antibodies. So in this line, there is a new paper which is discussing about the role of this agnostic autoantibodies against these receptors. So in the presence of their natural ligand, like such as angiotensin 2 and ET1, the presence of these scleroderma-related autoantibodies against these receptors is playing a synergistic role, and it is leading to acceleration of these constriction properties. So this has been implicated in scleroderma renal crisis. So when we study these antibodies in the context of scleroderma, we should be aware that they also occur as natural antibodies, may not have any role at all. And just studying ELISAs of these antibodies may not be enough, and we need to know whether they have functional significance at all or not. They have a role in a lot of other varied conditions as previously discussed. Another new antibody, which is also G protein coupled receptor, which acts against it, is called as the sphingosine 1-phosphate receptor. This has been recently found to be associated with PHN in iron. So there are other studies which have linked the presence of these antibodies. Both these antibodies co-occur. They do not occur in isolation. They have been found to be, been found in association with anti-topoisomerase antibody. They have been associated with other organ involvement like fibrosis, PH-SRC, and death as well. So you can see that the presence of these antibodies are associated with mortality in scleroderma. So this is about how the injury happens. So now let's get into why there is a defective vascular repair. There is an injury, it is a common, it is probably happens more commonly than we know, but as long as the repair processes are working well, it may not lead on to things which happen in scleroderma. So let's try to understand why there is defective vascular repair in scleroderma. So we need to understand two concepts. One is angiogenesis, other is vasculogenesis. Angiogenesis is sprouting of vessels due to local processes. Already injured vessel may lead to new vessel formation via a lot of local factors. So vasculogenesis involves endothelial progenitor cells, which are from bone marrow. So both the processes are impaired in scleroderma. It may be due to dysregulated crosstalk between pro-angiogenic and anti-angiogenic factors. It may be because of impaired interaction between endothelial cells and pericytes. It may be also due to alteration in epigenetic factors. Let's get into one or two factors and understand a little bit in detail. This is what I was telling. So whenever there is an endothelial injury, so there is sprouting of new vessels, which is called angiogenesis, or we may need endothelial progenitor cells which come from bone marrow and will lead to vasculogenesis. If that doesn't happen, all these other processes will happen, which we will be getting. So there are a lot of pro and anti-angiogenic factors. The most important of which is VEGF, TGF, platelet-derived growth factor, and other factors. Some of these chemokines. Inhibitors are angiopoietin, angiostatin, some chemokines, endostatin, etc. So a balance will always be there. Both these factors are released whenever there is endothelial injury. This balance is disrupted in scleroderma. So some of the defective responses of endothelial cells to pro-angiogenic factors may be due to some transcription factors like FLE1 and FRA2. These two are important because we have mouse models. So the far too overexpressing mice have defective endothelial cells and defective angiogenesis. This FLE1 repression, that is also leading to proliferative obliterative vasculopathy. The other important factors which have been discussed are CXCR4 receptor underexpression and another factor called MMP12. This molecule will lead to cleavage of this urokinase type plasminogen activator and lead to failure of this angiogenesis program. So these are the other factors which we need to be aware of. Defective vasculogenesis has been linked to occurrence of new DUs in scleroderma, and pentraxin 3 is one of the factors which are involved in suppression of vasculogenesis. And also it is known that EPC precursors from a known scleroderma patient will have a defective proliferation in cultures as well. So the precursors themselves are defective in nature due to various factors. So in this context, a lot of discussion is there about what are these endothelial progenitor cell subset, because they have also been studied as biomarkers in scleroderma. So there are, it is somewhat of a difficult subset to study in culture medium, etc. So there have been previously some confusion in nomenclature, etc. But however, now we know that they are of two types. One is endothelial colony forming unit, which are not hematopoietic in origin, and they are the ones which can lead to new vessel formation at sites of injury. The other is hematopoietic in origin, which are of two types, monocytic and conventional EPCs. These monocytic EPCs are of interest because they behave something like M2 phenotype of macrophages, which we know is dysregulated in scleroderma and is involved in pathogenesis. It has been known in studies which involve tocilizumab that this leads to downregulation of these M2 associated genes. So what we know is these monocytic EPCs are occurring because there is already defective vasculogenesis and angiogenesis happening, and in response to these factors, and they are capable of converting into fibroblasts. So this is one of the cells which are contributing to the fibroblast phenotype, which will lead to fibrosis eventually. So the other transcription factors which are involved in defective angiogenesis is CCN3, the downregulation of which will lead to impaired angiogenesis, and these epigenetic factor. This is overexpression of this particular factor, EZH2, is also involved in defective angiogenesis. So now coming to the last part of the talk, there is endothelial cell apoptosis, which will lead to capillary loss of capillary network and destructive vasculopathy. There is another important thing which will lead to contribute to fibrosis, that is endothelial cell activation. So endothelial cell injury due to any etiology may lead to activation of endothelial cells due to humoral and local factors. So endothelial cell itself will be involved in chronic immune activation. It also contributes to activation of platelet and coagulation factor. It may itself, the activated endothelial cell may itself stimulate proliferation and activation of resident fibroblast via some of the factors like CTGF. Okay. So the microvascular endothelial cell derived from scleroderma is known to recruit and activate dermal fibroblasts by induction of this transcription factor, this path. Okay. So these are the things which we know about endothelial cell activation now from papers which have been published earlier as well as recently. So summarizing what happens during an endothelial injury, this is a pictorial representation from a nephrology journal. What they are telling is when there is an endothelial cell injury, when the intact endothelium will have this glycocalyx layer, which will prevent adhesion of other microparticles and leukocytes, etc. Whenever there is an injury, these glycocalyx and the selectins and all are getting lost. That is how it leads to sticky endothelial surface. So this will lead to the infiltration of these leukocytes. They will stick and they are able to go inside. There is this, the endothelial cells lose their contact with the basement membrane. They will get shed and they may be seen in the circulation. This contact, this close interaction between the pericyte and endothelial cells are also lost, which will also lead to injury. So this is the last part of my discussion. This is relating to endothelial mesenchymal transition. So these myofibroblasts, as you know, are the central cells which are involved in the fibrosis process in scleroderma. It can be derived from a lot of cells. This is already well known. It can be derived from epithelial cell, endothelial cell, some other cells like macrophages, adipocytes, etc. So we are interested today in endothelial mesenchymal transition. So how do we know that an endothelial cell is transitioning to this fibroblast-like phenotype? There is downregulation of endothelial-specific markers like CD31 and vascular endothelial cadherin and von Willebrand factor. There is upregulation of molecules which are suggestive of a myofibroblast phenotype like alpha SMA, S100A4 and fibroblast-specific protein, and SNAIL1. This is a transcription factor, as we will be discussing, which is having a central role. So one important process which is involved in endothelial mesenchymal transition is significant downregulation of FLE1. We have discussed this earlier also. This is involved. This downregulation is involved in defective angiogenesis. This downregulation is also a hallmark to suggest that this endothelial cell is getting transformed into myofibroblast. So there are some interesting studies which have proven that there is endothelial mesenchymal transmission happening in inside the body. This is from the lung. You can see that these brown staining molecules, they are endothelial cells. They are not limited to the luminal surfaces. They are going inside within the subendothelial matrix areas. So that suggests that they are not limited to the lumen of the capillaries, and they are transforming and they are going to some other locations which are involved in fibrosis. And also you can see that these endothelial cells are expressing mesenchymal endo-EMT phenotype. These are the molecules which I have already discussed. So it is expressing both endothelial as well as mesenchymal markers. So you can see that this is happening with addition of TGF2, human derived mesenchymal vascular endothelial cells after 48 to 72 hours. If you are adding TGF-beta or you are adding SSC serum, it is getting transformed into this phenotype, the spindle-shaped phenotype, which is suggestive of a fibroblast phenotype. You can also see that it is leading to contraction. So this is an interesting experiment which was published in 2017, showing that this is happening in the appropriate humoral and local factors. These endothelial cells can transform themselves into mesenchymal cells, which this process is called as endo-EMT. So there are important contributors to endothelial mesenchymal transmission, the most important of which is TGF-beta and its related pathway. Lot of other factors like these are all these WNT, Notch and Hedgehog, these are involved in the embryonic processes. Caveolin is also an important molecule. There has been studies and mice models of these also, but most of them are directly or indirectly involving the TGF-beta itself. You can also see that SNAIL1 is an important thing. So the translocation of this SNAIL1, a transcription factor from cytoplasm to nucleus, is an important event which will mark the transformation of an endothelial cell to mesenchymal cell. I'll be just discussing one or two molecules of interest which may have therapeutic potential. The first of it is endothelin-1. In experiments, it has been shown that this AT1 is directly involved in endo-EMT process, and it is usually mutual. These TGF-beta and ET1 are acting mutually in getting about this process, and SMAT phosphorylation was observed after treatment with this molecule to this systemic sclerosis derived endothelial cells. And it has also been shown that macitentan inhibited this endo-EMT process, which has been brought about by both these molecules. So thereby telling that there may be some role of these molecules in treatment. So the other important molecule which is extensively studied is CXCL4. It has been shown in various mouse models. There is increased level of this CXCL4 in the mouse model, and when there is a knockout mouse models of CXCL4 will be there. The essential role has been proven. When there is a knockout, this is not happening. Tissue homeostasis is maintained and fibrosis is not happening. CXCL4 is known to directly induce myofibroblast differentiation via the endothelial cells and other precursor cells by stimulating this process, endothelial to mesenchymal transmission via metabolic changes. You can see that this is CXCL4 is not described in this diagram. So this is a process which is somewhat independent of TGF-beta. So the other molecules of interest are oncostatin M, leukotriene B4, BMP. Leukotriene B4 and BMP7 involve both the same mTOR pathway, both of them. And another important molecule which has been shown is PAG17. The mice lacking this PAG17 is leading to spontaneous skin fibrosis. So therapeutic targets as of now, which they are exploring, is this ET1 antagonism, soluble guanylate, that is riociguat, and there are some new molecules of this guanylate cyclase activators. So stimulators are the riociguat and related molecules. There are some newer molecules which are being tried to target these processes, endo-MT. So in conclusion, endothelial injury by various processes such as virus and antibodies will lead to endothelial cell apoptosis. It will lead to endothelial cell activation. This may lead to capillary injury in the presence of a defective vascular repair mechanisms, both angiogenesis and vasculogenesis, and simultaneously occurring immune dysregulation. This will lead to a lot of things. One of the important things is the transformation of endothelial cell to myofibroblast, which will lead to tissue fibrosis. The other thing is proliferative vasculopathy. This involves fibrosis which is happening in subendothelial level and occlusive vasculopathy. So this also leads to some other clinical manifestations like PH-SRC and digital ulcer. So this is in short about endothelial cell injury and endothelial dysfunction, which is contributing to scleroderma. Thank you.
Thank you so much, Dr. Ramya. A very excellent, lucid, excellent talk, and you very vividly described the pathogenesis, the vascular injury, and the contribution to fibrosis. I just wanted to ask, are any of these markers or antibody, anything is tested actually, or it's still in at a research stage?
We are not in the level of clinical biomarker stage, but there are several studies which have looked into something like these the vascular, the endothelial cell precursor cells, no, they have been looked at as a biomarker. The other biomarkers, there are extensively studied, but even the CXCL4 is quite well studied. I have looked at one NEJM paper, which was previously, they have linked CXCL4 with 2PH and ILD in scleroderma patients, but I don't think any of them have translational potential
right now. Yeah. Okay. Any students want to ask any more questions? Okay. Thank you so much. Thank you for an excellent talk, taking time out on a Sunday and joining us. Yeah, I do hope to meet you soon at IROCON Bangalore. Yeah, all the best to you. Yeah, thank you very much. Okay, I'll close the session. Bye-bye. Have a good Sunday.